without further ado, advanced practice provider with Brianne Buchanan, PAC, The Expanding World of Cellular Therapy. And we've got a bio there, but we've got some top facts. So, Brianne, welcome. Good to see you. So glad to have you here.
Great to be here, Tim. Thanks.
Absolutely. So let's see. Started your career in outreach oncology, where you often flew in a small flew a small plane, so you're a pilot?
In a small plane. Okay. No, I did not fly the plane. No, definitely not.
All right. Or drove 3 hours to clinic each day. Wow.
Yes.
That's dedication.
Yes, it was it was fun and exciting.
Yeah, I'll bet.
Every day was different.
I'll bet. Spent most of your career in bone marrow transplantation departments, where you tended to feel like most of your patients were nearly family.
Yep, it's definitely the opposite of an urgent care.
Yeah.
You get to know your patients really, really well.
Absolutely. Bikes or walks to work. Great go-to for a patient when it snows.
That's right. That's right. The pros and cons of living close by.
Yeah, we know that well.
Yeah.
My wife is a nurse and has spent more than one night here on.
Luckily, it has not happened often.
Okay,
So
yeah.
This isn't a big snow area.
No,
so not as much of a problem, more of a benefit.
Yeah, less and less so. Developed her love of bone marrow transplant after being a BMT elective in PA at the NIH with many of the leaders in the field.
Yeah, that's right. One of my alumni from my school at George Washington worked at the NIH in the bone marrow transplant department. And so that was one of my kind of electives because she had been an alumni and I really fell in love with it there.
Yeah.
And so I was able to continue with it later on.
That's great. I always love to hear a little about folks' career trajectories as well. And then number one, provides CAR T customer service and is motivated to increase access to CAR T treatment in North Carolina.
That's right. And that's what we're going to be talking about today.
Great. Good segue. One question. What's one thing we should know outside of your professional bio?
Oh gosh, there's a lot. I probably mostly enjoy doing things outdoors. So while we certainly all operate in the hospital, any kind of hiking and things like that are ideal. And last summer was able to actually, as we mentioned earlier, take my family to Japan, and we were actually able to hike Mount Fuji.
Oh my gosh!
So that was super fun.
Oh my gosh!
Yeah,
that
was
jealous.
really great.
Yeah,
it was really great.
Sounds
quite
nice.
an experience.
I'll bet. Well, I mentioned Poll Everywhere. Our first question, always kind of a softball. Cellular therapy, also known as cell-based therapy, is a medical treatment that uses cells to treat or prevent disease. True or false? Here's our mandatory our CME and our nursing disclosures. You've seen them. And we'll wait about 5 more seconds. Again, this is an easy one, so we don't need to wait too long. How are they doing? They're going pretty heavily on the true front. So doing all right?
I think that is definitely true, yes.
Oh, okay,
yes.
Good. So the expanding world of cellular therapy, I'm going to turn the controls over to you, and you can take it away.
Great. So today, this is my favorite topic, as anyone who at work knows me at all. We're going to talk about cellular therapy and kind of hone in on CAR T therapy specifically. So the main goals, we're going to briefly go over an overview of what CAR T immunotherapy is for those not as familiar with it. We're going to do this fairly briefly. If you have an interest in learning more about CAR T in general, my colleague Megan McElfresh actually did a Lineberger Cancer Network talk in December of last year, which is available, I believe, on the website. It's a great resource for that if you're interested more in the toxicities of general CAR T care that we're doing now in the clinic. What I'd like to do more is describe the current CAR T therapies that are available in clinical trials as a means of showing kind of where we're going in the field and what kind of excitement is coming as far as CAR T therapy. And then we'll talk a little bit about recognizing patients that might be appropriate for clinical trials, as that's really kind of how we do advancements. So first question, so CAR T therapy is currently approved to treat which of these diseases?
All right. So, and I know these can be small on some folks' screens. So A, melanoma, B, lymphoma, leukemia, and multiple myeloma, C, breast cancers, and D, systemic lupus,
Erythematous.
Thank
yes.
you. Thank you. I think you say that word more than I do. So
Definitely. Yeah.
and while they're thinking about it, yes, we absolutely have that video that you mentioned, either as just a video or in our learning portal. And so everything stays for credit for 2 years in the learning portal, and we actually have over 1,000 videos in the library.
Yeah,
So,
it's a really nice resource.
thanks. Well, how are they doing?
Okay, doing great. So we've got everyone so far with the correct answer, which is lymphoma, leukemia, and multiple myeloma. These are our blood cancers and the only area of diseases which have currently FDA-approved products for CAR T therapy. So as we discussed kind of in the initial poll everywhere question, cell therapy is essentially the transfer of a specific cell type into a person to treat or prevent a disease. That's the umbrella term for what cell therapy is. Under that umbrella, we have several types of treatments. There's stem cell transplant, which has been around for a long time and is well known. There is chimeric antigen T cell therapy, which is CAR T therapy. This is what I'm going to focus on today. And then there's also tumor infiltrating lymphocytes. This does have a FDA-approved product to treat melanoma. Gene therapy, where genes are edited within cells that are then used to treat diseases such as sickle cell disease and thalassemia, both of those which are also FDA approved. And then mesenchymal stem cells, which are used in a lot of regenerative therapies. Now, a brief overview of what is CAR T therapy for those who are not familiar with it. It is a cellular therapy. It's basically harnessing the immune system to treat cancers. What it does is takes a patient's own T cells, a type of white blood cell, attaches a antigen receptor called a CAR to these, and then instills those into the patient to treat and kill their cancer cells. They're antigens that are targeted on the cancer cells. The most common ones are going to be CD19 and BCMA, and you'll see that those are for all of those blood cancers that we mentioned earlier. These are usually used to treat relapsed or refractory blood cancers, hematologic malignancies currently for the approved products, but these are starting to be moved earlier line to treat these in earlier diseases, but the focus is still only on approval for blood cancers. And you do have to have these given at a specialized center, which can administer the cells, but also manage the toxicities from them. Toxicities are primarily going to be cytokine release syndrome, or CRS, immune effector cell-associated neurotoxicity syndrome, or ICANS, cytopenias, which can be very prolonged, hypogammaglobulinemia, and hemophagocytic lymphohistiocytosis. You want to talk about one that's a little tricky to say.
Yeah.
HLH. This is now actually being called IECHS to add the immune effector cell tag to make it a little bit more specialized. Again, if you want to hear about those toxicities, Megan did a great job on the talk from December. The general process for almost all CAR T cell therapy is essentially the same. So down at number 1, you have where we use leukapheresis to remove from the patient's blood as many of the white blood cells and then isolate the T cells from this. A CAR, or that antigen receptor complex, is attached to the T cells, which are then grown in the lab as much as possible. Once we grow these, we then will give the patient the chemotherapy, which will deplete their own T cells temporarily to allow longer persistence of the CAR T cells inside the body, and then we'll infuse the cells into the patient. The production and manufacture of the cells takes on average around 4 weeks for most products, kind of give or take about a week or two. After the cells are given, they usually require about 4 weeks of monitoring. These are all the commercially approved CAR T products. You'll see the kind of brand name, the mostly impronounceable generic name, and then the indications, which are all going to be these blood cancers of lymphoma. The leukemias are only currently approved for B-cell acute lymphocytic leukemias, and then multiple myelomas. And you'll see there's only 2 really antigen targets that are approved, in that CD19 and BCMA. Since I initially created these slides, I had to, of course, adjust. We had a new approval last Friday for another product for B-cell ALL, which is a CD19 product. So even in the FDA-approved world, this is a rapidly growing field. Now, for current clinical trials, what I wanted to really focus on was a bit of a speed dating approach to where the field is going. There is way too much innovation right now to be encompassed in a 1-hour talk. And so I just wanted to highlight some of the things that I think are good illustrations of different modes that are being taken to really expand how we use CAR T, make it better, access other types of diseases or patients, and just kind of advance the field of cancer care in general. I'm going to start with ones that are being adjusted for the hematologic malignancies, so the blood cancers. This is where we have most of our core data. So where are we going to try to improve upon what we have already? We already have some good success with especially our lymphomas, multiple myelomas, and some of our leukemias. But how can we take what we have and look at something new? So one of the goals that we need to do is we are having many patients now more and more be treated with CAR T therapy, and not every patient is cured. And so where do you go once you have already received CAR T treatment or another T-cell engaging therapy like bispecific antibodies? And so looking for additional cell therapy that patients can use as the next line is one certain area of investigation. Looking for new targets on these cancer cells is definitely a nice way of expanding how you can treat these cancer cells. Expanding targets, meaning that having dual targets or targeting multiple receptors on that cancer cell is going to give you some potentially greater efficacy, and so you'll be able to treat patients with more success rates. Obviously, faster manufacturing. Some of these patients, especially if they're relapsed or refractory, they don't really have 4 weeks to sit around and wait for cells to be made, and so that's a hindrance. And then also, of course, reduction in cost. Most of these products are on the order of about $500,000 for each cellular therapy product, and so how do we have a way to reduce this cost and make it more accessible to patients all over? One way that we're looking at this is to look at types of blood cancers which do not currently have any approved treatments. One of those is Hodgkin's lymphoma. So the majority of Hodgkin's patients are actually cured with first-line chemotherapy, which is excellent. However, about 15% will be refractory or progress after that first line. And then the second line is generally an autologous stem cell transplant. Of those patients who receive that, half will still progress again, and those really do not have many effective treatment regimens that will be giving them any kind of duration of response. And so CD30 is an antigen that is located on Reed-Sternberg cells found in Hodgkin's lymphoma. There was a trial performed here actually at UNC where we used 32 patients, had 32 patients with some really impressive results, with the overall response rate was 72%, complete response rate was 59%, and this is a very difficult to treat population. This is the only trial of this kind in the United States, and so we're pretty proud of it over here. The toxicities as well, treating patients and getting success is also tempered by how they tolerate the treatment, and this particular CAR T has had very minimal side effects, with the initial trial just showing patients with grade 1 cytokine release, which is typically just a fever, and none of the neurotoxicity that we can see with some of the CD19 CAR Ts. There's currently an ongoing, that trial is now closed, there's currently an ongoing trial looking at CD30 coupled with a CCR4, which helps it to kind of home in on its target for Hodgkin's disease. Another target is kappa. Kappa light chains can be effective in treating some B-cell malignancies. This is typically diffuse large B-cell, and there has been some data showing that there is just as effective as a target as a CD19. The toxicities are very similar in that you still will see cytokine release and neurotoxicity, but they tend to be a bit milder. And it is a very nice treatment when we talk about patients that have had some of these approved products that have then progressed. And so you may have a diffuse large B-cell patient that has progressed on a CD19 CAR T, and then you can use this afterwards if you're looking for further effect. There is typically especially when you're using the same disease and you're going from one CAR T to another, most clinical trials that you'll see will require a type of washout period, anywhere between 6 months to a year from their last CAR T treatment, and that's mostly just not to muddy the waters between the effect of the two. Multiple myeloma. So if you remember from the previous slide, the only approved products for multiple myeloma in the CAR T world are BCMA targeted. The bispecifics antibodies used for multiple myeloma are being used for BCMA as well, but also for a target called GPRC5D. In parentheses, you'll see that full name, which I don't know many people who can probably recite off the top of their head. But GPRC5D is very effective at treating multiple myeloma in the bispecific world. There is now a CAR T targeting that as well. So our patients with multiple myeloma, which is an incurable disease currently, this is a nice step where they may be able to get another kind of treatment-free interval of some duration from a cellular therapy. The problem with GPRC5D, or really for any CAR T, is going to be that if it's located on the cancer cells, your target may be located on other healthy cells as well. For GPRC5D specifically, that antigen is also found on skin, nail, and hair follicles, and so a lot of your toxicities will be coming in those areas. So you have to really kind of find a great target. Now, and I have to say, the visuals for giving a talk on something called a CAR are actually pretty fun to find. So I like this one. I have no idea where this occurred, but I would probably pay for tickets to go see it. So dual targeting CARs. This is pretty exciting. So 2 targets, 1 CAR T. So primarily this is being looked at in lymphomas and leukemias where we have more than one known effective antigen target. So what is hoped for here is that you have increased binding of the cancer cell to the CAR, and so you can have more efficacy in being able to treat both targets. And so if a cell has lost its CD19, you can capture it, for example, with CD20, as you see in that first example for lymphoma. Now, the downside of that is if you have greater binding, you may have increased toxicity as well with cytokine release and the neurotoxicity. So that's also being looked at also. There are several trials throughout the country looking at CD19 and 20 for lymphomas, CD19 and CD22 for leukemias, and then CD19 and BCMA for multiple myeloma, which is pretty interesting. Allogeneic CARs. So this is something that I really have hope is a large part of the future of CAR T. I think it answers a lot of our struggles in the CAR T world that make it a treatment that will be able to impact people all over and really increase access. Now, they're not problem-free, however. So allogeneic CAR Ts are off-the-shelf CAR Ts. So the T cells, the apheresis is done on volunteer donors, and then the CAR Ts are made and administered to your patient. The benefits are obviously faster availability. If you can create these CAR Ts and have them sitting in a lab, then when you need them, you just ship them to the person, and you don't have that 4-week manufacturing time, which is really significant for people with fast-growing disease. If you use a volunteer donor, you also have very healthy T cells. These patients are often very heavily pretreated, and when you do that, their T cells are a little beaten up, and we end up with a situation called T cell exhaustion, where they may not be as active as you would like, and the CAR T cells may not work as well. So healthy volunteers equal healthy T cells, which is great. Also lower cost. If you can manufacture in mass a bunch of CAR Ts instead of having to create a individual product for each patient, then you can really have a potential for decreasing the cost of these, which is a huge problem for CAR T for the long term. Downsides: when you're using someone else's cells, they tend to not like being put in someone else's body. And so you really have to worry about kind of a graft versus host situation with the CAR T cells coming in. And there's a lot of gene editing ways that people are looking at manufacturing those so that they don't have that risk. They also tend to have a shorter lifespan. There's more of a chance of them getting killed off by the host's immune system, and so they may not persist as long, and that may decrease their ability to be effective at getting patients closer to a cure. The also potential is to need to match the cells. Again, it's being looked at right now to remove complexes which can lead to host rejection or graft versus host disease, and that will hopefully help. But otherwise, potentially, you may need to match some of these CAR T cells to the patient, which would be challenging. Here's a little schematic of how it could potentially work. You have healthy donors. You collect their blood cells, and then you insert your CAR. The gene editing aspect is what I was speaking of, where you need to adjust them so that they don't just go in and attack the host. Once you create that, then you can grow them and have them sitting on the shelf waiting for patients who need treatment. Looking at clinical trials outside of the blood cancer world. So where can CAR T cells be used outside of leukemias, lymphomas, and multiple myelomas? There is a large growth of research in this topic. Certainly, immunotherapy in general is rapidly expanding, and so looking at this as kind of a future of a lot of treatments, and solid tumors are definitely one of the more challenging aspects of that. Now, when we administer CAR T cells, how are they given? The place where they are definitely not given is either intraventricularly into the brain, intravenously into the blood system, transdermally through the skin, or directly into the abdomen. And this is going to be, going to let that kind of sit for a bit.
All right. Thank you all for jumping in and taking your best guesses at answers, or maybe you know that. While we're waiting for those answers to come in, so how, if one wants to be a donor, what's the process for that?
Well, so I think at this point you would need to approach the groups who are doing this as part of a clinical CAR T trial.
Gotcha.
The need for donors is not high because you don't need a large amount of product to be able to make a large amount of CAR Ts.
Gotcha.
So yeah, it's not the same quite as the stem cell donor for transplant, which we're always in need of, and that's through the National Marrow Donor Program.
Gotcha. Good to know. Okay.
Which is having a drive on UNC's campus next week.
Oh, plug there you go. Plug for
yeah.
that. Great. And you can reach out to us at that shared at that UNCLCN at unc.edu if you want to find out details.
Great.
How are they doing?
This is good. I'm glad this was a little bit more challenging. I was trying to add something that was maybe trick some people. So CAR T cells are not ever given actually transdermally through the skin. So the majority of people got that correct, which is great. We're going to talk about some examples of the others, which I hope is at least as interesting to other people as I find it. So in the solid tumor world, where can we really work on improving cellular immunotherapy? The first challenge is going to be you have to find an effective target. CD19 in the blood cancers has been fantastic from the get-go, and so that is really what has thrown all CAR T therapy into a high innovation field. But what can we use for solid tumors? You want to make sure, as we talked about with the GPRC5D, that your target for your cancer is not located on a lot of healthy cells, because if it attacks those, then you run into a lot of toxicities and trouble. Then for solid tumors, they have a little more unique situation where they have a very toxic microenvironment surrounding the tumor. And so you have to really find a way for your CAR T cells or your cells to be able to penetrate that microenvironment, to be able to get to the cancer cells of the tumor and to attack it. And then with solid tumors also, we really need to focus on in general for all treatments, but hopefully this will be a new way to add some hope to some cancers that have very limited treatment modalities, because it's a new way of looking at it as opposed to what we've looked at for decades as far as more pharmaceuticals. So hopefully providing a little bit of hope. A example of our first one of looking at finding the correct target for cancers. HER2 is a antigen that is located on a lot of solid tumors, particularly in breast cancers as well as GI and some lung cancers. The clinical trial, which is currently accruing, is using a CAR-M. It's actually, I miswrote that. It's actually a CAR monocyte, which then differentiates into a macrophage. The previous trial was a macrophage trial. T cells really struggle to invade the tumor microenvironment, and so this particular clinical trial, which is open, utilizes monocytes, which tend to be rooted into the tumor microenvironment more easily. Once they get in there, the previous trial data has shown that they can recognize these cancer cells and then also help to recruit T cells to attack the same antigen and sensitize that area. It adds to the T cells being able to penetrate the microenvironment. So you're essentially using different immune cells to help each other out and to gang attack that cancer cell to make sure that they can start to be able to penetrate that microenvironment that has been protective of it. The HER2 antigen is overexpressed on a lot of breast and GI cancers, and so this is primarily the current trial that is available, allows for mostly breast and GI cancers. And then the requirements for any kind of HER2, there are some pharmaceuticals that are very effective at treating HER2 as well. So all of the CAR T trials will be earlier phase, and so they will be requiring you to have failed usually the pharmaceutical that's already FDA approved. When you have a CAR T targeting something that has a pharmaceutical that is FDA approved, that's generally going to be a requirement. Now, another target that is really interesting is B7H3. This is located on a variety of different solid tumors and can also be found in malignant ascites and circulating in blood when you see circulating tumor cells. There are many cancers where this is found. Ovarian cancer is an example. These can be treated in general. So ovarian cancers do have data that has been shown that uses hyperthermic intraperitoneal chemotherapy. And so they heat the chemotherapy, instill it directly into a patient's abdomen in the OR, and then let that kind of marinate the cancer, and it helps to treat the cancer cells, being able to penetrate that area of the microenvironment surrounding those a little bit easier than instilling it through the blood. And so since ovarian cancer has been shown to have that work well, we have a current clinical phase 1 trial that utilizes a intra-abdominal catheter where the CAR T cells are actually infused directly into the peritoneal space to impact the cancer directly. There's also clinical trials going on for metastatic pancreatic cancer and triple-negative breast cancer, all looking at the B7H3 antigen. So a lot of hope for this antigen to be able to impact, hopefully, a lot of solid tumor cancers. When you just to go back really quick, a interesting thing that you can see with some of the intraperitoneal other treatments for ovarian cancer is when the cells are infused through the intra-abdominal catheter, to make sure that the tumor is coated well, the patient is actually rotated. And so you do a side to side on their back rotation back and forth to make sure that the cancer is actually exposed to as many of those CAR T cells as possible. I just think that's a little bit fascinating.
Yeah.
Kind of strange. So this one I really wanted to focus on because I think that it is really exciting to see when you can have something that has a very bleak picture and to begin to see some changes. I've been a PA for close to 20 years, and when you see something really kind of stalling as far as being able to advance, it's a little discouraging, and so to see some light at that tunnel is really nice. And I think a good example of that is going to be CAR T therapy that we're using for glioblastoma brain tumors. These are very aggressive brain tumors. They're the most common type in adults. The standard of care has been unchanged since 2005. That includes surgical resection of the tumor as much as possible in combination with radiation and temozolomide. It is, typo there, incurable disease with a median survival of only 15 months, which is abysmal. Current 5-year survival is about 5%. So this is definitely an area that needs improvement. All glioblastomas will eventually progress, and there is really no defined standard of care at recurrence. There is some research going on, but it is definitely an area of critical need. So in 2016, CAR T treatments were used. There is a case study of a patient here published in the New England Journal of Medicine looking at a CAR T that was instilled through a Ommaya catheter. So an Ommaya catheter is a catheter very similar to a portacath that would be used in the chest. This is implanted actually under the scalp, and there is a catheter that goes straight down into the brain. We place those here into the tumor bed, and so the idea is to get the catheter as close to the tumor itself as possible inside the brain. The cells are then instilled into that reservoir to go directly to the tumor bed inside the brain. The case study, which in 2016 was so exciting, did see a complete response of the brain tumor in this particular patient that lasted about 7.5 months. This was given with multiple infusions, and so this was not a one-and-done kind of treatment in this case, but it was really exciting. And so that has led to a lot of interest in the field of trying CAR T therapy for glioblastomas. Newsworthy, earlier this year, Massachusetts General released an abstract of their trial, which is still ongoing, looking at a CAR T targeting EGFR paired with a TEAM, which is a T-cell engaging activating molecule. This was given to patients who had all recurred following standard of care. They had received temozolomide and radiation therapy and had progression of their cancer. The cells were again infused directly into the brain, and they did see dramatic reductions in tumor size. One patient actually achieved a near entire resolution. All eventually did progress, however, so this is definitely not a done treatment. There are still some advances we need to look at. How do we take something that's effective and then continue to make it better? But being able to see a signal where you can actually have a treatment that could do something like this picture that you can see is really exciting. So if you look at the MRI for participant 3, the first MRI is done at day -7 before the infusion. This was after a singular infusion on day 5, the repeat MRI showed a dramatic response. So not only was this effective, it was rapidly effective. Really pretty remarkable. So we have a big interest in this here at UNC as well. So B7H3 is another antigen located on glioblastoma cells. We have developed this quite a bit locally here, and so glioblastomas tend to have about 77% of the samples show high expression of this antigen. And not only is it located on primary brain tumor cells, but even after treatment with temozolomide and radiation therapy, you'll still see this, so you can use it in recurrent tumors as well. They're retaining their B7H3 expression. There is also a monoclonal antibody that did show some anti-tumor activity against the brain tumor. So we have treated several patients here already. The B7H3 CAR T, like most phase 1 clinical trials, is in a dose escalating safety trial, and so there are going to be 6 dose levels here. The Ommaya reservoir is placed. The infusions are given weekly for 3 weeks, and then we assess response at 6 weeks. The dose levels, currently we're on dose level 3. What we've seen so far is that we have seen several stable responses with evidence of immune response at the area of the tumor, and then we've actually had a partial response for a patient that was on dose level 2. So fireworks may not seem like a partial response is fireworks, but when you're talking about something like a glioblastoma and really seeing activity, it really is. These patients are pretty desperate for some sort of response, and this is giving hope where there wasn't hope before. So let's stop talking about cancer. I know this is a cancer-directed talk, but...
Hey, wait a minute. Did we talk about this?
Yeah, slip it in there. So CAR Ts, we can use them for everything. So where can we use cellular therapy to treat disease by harnessing the immune system? Well, how about autoimmune diseases? Areas that autoimmune disorders really need to focus on, it's going to be different than our cancer population. Chronic diseases tend to have a longer course, and when you're talking about something that people will be living with for a long time, you need to have a low risk of toxicity. These are not patients who want to risk their life or major debility from their treatment to be able to have control over their disease. So that's important to have a low toxicity profile for these CAR T products. Also, the goal really needs to be reducing the need for lifelong immune suppression. A lot of these patients require it for their entire lives, and so it's more of a focus on the third one, which is going to be quality of life for this longer duration. So when we're talking about autoimmune diseases, this may be a bit of a guess, but a common antigen target that we would use would be CD19, B7H3, HER2, or EGFR. And I'll let people kind of give that a little chat. Sorry, I slipped in a little non-answer.
Oh, no, that is quite all right. And while we're waiting for folks to think about that, you know, kind of like on Netflix where it says, if you like this video, you might like this other one. I'll say that we had Dr. Higgins back at the beginning of the year,
yes.
and he actually brought in one of those little reservoirs and talked about it. And then talking about glioblastomas, we had a talk a while back about ketogenic diet and glioblastomas.
Yeah,
It was
that's
really fascinating.
They have a really comprehensive, patient comprehensive program where they kind of really treat all the aspects. But yeah, Dr. Higgins is fantastic. He replaces all our Omayas.
Oh, okay. Yeah, we loved having him here.
Yeah.
So and it was fun that he brought that in and we could take a look at that.
That is interesting.
So,
yeah.
Yeah. Well,
should have asked him for one.
Yeah. So how are they doing?
Okay, this is excellent. Great. Everyone is correct right here that this is CD19. CD19 will be located on B cells, which are the primary cell that's wreaking havoc when they become autosensitized in autoimmune disorders. So what do we have so far as information on what CAR T can do in these diseases? One of the areas that is really being looked at heavily right now is using CD19 CAR Ts, which we have a lot of experience making, but using them for systemic lupus erythematosus. See, it just rolls off the tongue. Yeah. Lupus. We'll just call it lupus. And this can have a variety of manifestations. It can be a really debilitating disease that can affect many of the organ systems and just make patients' daily life a hardship. And so the treatments for it often involve long-term steroid use and immune suppressants with various side effects, especially over the long term. There was a early trial published in Nature Medicine that showed a complete remission of lupus symptoms. It's a very small cohort of about 5 patients receiving CD19 CAR T therapy after receiving some lymphodepletion like we do in traditional CD19 CAR T treatments. The remissions lasted greater than 8 months at the end of data collection, and so those may have continued longer than that. This was a very kind of brief trial, and then these patients were off immune suppression at that time. So this is a kind of a first in the lupus world as far as CAR T treatments. The CD19s targeting the B cells, which is the problem cell in lupus, but in this trial they actually saw that the B cells, which are part of a person's normal healthy immune system, also recovered after the CAR T treatment, but the B cells that recovered were not autosensitized to create disease. They were actually just normal naive B cells functioning as B cells should. And so it kind of reset the immune system, which is the goal of autoimmune CAR T therapy. Also, we talked about low toxicity is important. On this trial, only mild grade 1 cytokine release syndrome was seen. So that was pretty great. There are some clinical trials ongoing looking at lupus treatment with CD19 CAR Ts. Now, myasthenia gravis. So this is a chronic autoimmune disorder. It results in a weakness of the skeletal muscles, and it is a problem with the communication between the muscle cells and the nerve cells. BCMA is located on plasma cells, causing much of this problem, and so that is the target for when we're looking at treating myasthenia gravis. This, because the patients often come in more debilitated because of general skeletal muscle weakness, lymphodepleting chemotherapy is very toxic, and so just too much for these patients. So the strategy that has been employed, which is a little bit different, but I think genius, is that they are giving more weekly doses. So without lymphodepleting chemotherapy, you don't have the same persistence of the CAR T, and so giving weekly doses gets on top of that. There is some initial phase 2 data that did show meaningful decreases in their symptoms with a decrease of their severity scores of those up to 9 months after treatment. So seeing some real success in that as well. Now, when we're talking about who qualifies for CAR T clinical trials, you asked me, everyone. No, just kidding. Okay, so if we're going to think about who would definitely not be a patient considered for a clinical CAR T trial, are we going to consider a patient with pancreatic cancer, a patient from a rural area, a patient with a rare solid tumor, or a pregnant woman? I'll let people kind of think about that for a sec.
All right. I certainly agree. The hypothermic chemotherapies really are fascinating, and that's going on with GI
yes.
treatment as well, right? I think we have somebody who specializes in that here.
Yeah, it's really interesting. I think when people think outside the box on how does that tumor work, and what's the best way to get at it? Outside of the traditional methods.
Right.
And who has the guts to do it the first time?
Yeah, I'll bet.
Yeah.
Okay, so which of the following would not be a patient considered?
All right, so I'm glad everyone got this correct. Pregnant women are almost exclusively excluded from CAR T clinical trials for very good reasons right now. So that would be it. But we really wanted to emphasize that solid tumors with pancreatic cancer, rare tumors, patients because of where they're living, we should really continue considering these patients for looking at clinical trials and having access to them. The best way to look for clinical trials for a patient is going to be clinicaltrials.gov. This is a big resource for all ongoing clinical trials in the U.S. So first step, query if a clinical trial is available. You can look at your patient as well. Usually patients need to be reasonably healthy, mostly because they need to be able to tolerate waiting to get through enrollment and begin treatment. Clinical trials typically are highly regulated, and so that to ensure safety of patients and to follow the right protocols, which often can take a little bit of a wait. And then some of our higher interest clinical trials may have a wait list as well. So keep that in mind. The other patients that you really should look at, though, is are they progressing past the standard of care? So they may be moving on to additional lines of therapy, but if they've passed really the biggest bang for the buck or the curative intent, then really start looking at clinical trials at that stage earlier in the process to make sure that if they do qualify for something, you don't miss an opportunity. And then definitely early consideration in rare or aggressive malignancies, so things like glioblastomas, pancreatic cancers, intraperitoneal cancers, anything with really limited treatment options from the get-go of diagnosis. That's really when you want to start exploring, are there trials available? What will be the full set of options to help you sequence what they're going to be getting? And always have a plan B. So we're all pretty much aware, hopefully, of barriers to clinical trial participation. This is something we should all think about and work to improve. Patients have, certainly some beliefs and attitudes towards clinical trials, some mistrust of the healthcare system and trials as well. I call that the guinea pig phenomenon of I don't want to be tested upon. And then also there's a lot of really practical considerations too, that they may have to travel a long way to get to a clinical trial site. They may worry about insurance coverage. Many clinical trials actually do require trial coverage through their insurance. They may have challenges with language or immigration status and concerns on their part of being able to participate. Healthcare providers, we can work on that the most. That's hopefully what I'm advocating for here, is that having limited awareness and knowledge of ongoing trials, there's so many out there that it really is a struggle to stay on top of it. And so that's why I want people to kind of keep it in the forefront of their mind that trials may be an option for patients, and that's really how we're going to advance and find these incredibly progressive treatments for patients to give hope where there hasn't been. But also time constraints. Everyone who's listening to this probably has time constraints in their daily life and their work life especially. And then non-cooperation of teammates. It may not be that everyone is geared towards additional work, because often this is not just going to be your normal workflow. It takes a little bit more effort to help these patients get to these trials. Then, of course, strict eligibility criteria. Sometimes complex clinical design, wait times, wait lists, limited trial enrollment. These are things that are always going to be something that we struggle with. And then institutional, I think the biggest thing there is probably going to be limited logistical support. We all need more support. We all need more help to get these patients taken care of, and decreasing the workload will be helpful. Common exclusion criteria, again, really can't enroll pregnant women. That's going to be a hard no. Then previous CAR T therapy is often a exclusion criteria, but not always. So please keep that in mind, that if they've had CAR T treatment, especially for the blood cancers, they may still qualify. Previous CAR T toxicity is usually a problem. And then uncontrolled active infections is almost entirely a exclusion criteria. significant organ dysfunction, oxygen dependence, renal failure, cardiomyopathies. These are often clinical trial exclusion criteria, but not always. So please look into that or push it towards someone who has a clinical trial open, and they'll be able to look at that for you. Currently, the approved CAR T centers in North Carolina, this is where I think I do like to emphasize that we need to improve our access to CAR T therapy. You will get even commercial products have to be at these centers, and we just need to get better about that. We need to improve our reach out to all the parts of North Carolina so that if a patient can benefit from CAR T, they have access to it. And so you'll see us here at UNC and Duke are in the Triangle. Atrium and Novant are in Winston-Salem, and then Levine and Novant are in Charlotte. So there's really, of those 6 centers, there's really only 3 areas in North Carolina which are serviced by CAR T centers. So one day, hopefully, we can bring CAR T therapy to every patient in their community and increase our improvement on outpatient treatments, reducing costs, moving manufacturing to in-house to improve on that, reducing all the toxicities, which we're continuing year by year getting better at, and standardizing reimbursement, which is a big problem. Just for interest's sake, if you would like to look at these later, this is a list of our currently open CAR T clinical trials. For blood cancers here, solid tumors are listed here, and autoimmune disorders are listed here. Many of the ones I talked about we have available here at UNC, with more coming through the line each month, it seems like. If you'd like to contact us, this number right here is for commercial or for clinical trial CAR T referrals. And so you can email that or call that number. Our intake form is on our website as well. Again, the visuals are super easy for CAR Talk and references. So thanks a lot. And I would like to say if anyone has any CAR T questions in general about clinical trials, commercial products, treating patients, what patients qualify, feel free to shoot me an email. It's a favorite topic.
Great. Thank you so much. This
Thanks,
has been a
Tim.
wealth of information. So we are open for questions now, so please go ahead and share those. While we're waiting, I'll mention, going back on my soapbox of if you like this, you might like that. Just a couple of weeks ago, Dr. Charlot did a great presentation on clinical trials, specifically called Shaping the Future of Cancer Health Equity, and talked about
that's great.
her program, CREATE, that dealing with equity and clinical trials.
I'll have to go and watch that
Yeah.
one.
Yeah,
no, I'm a
that's
huge advocate. It's how things happen for sure.
It's an amazing program that she's got going on.
Can't move forward without them.
So we're excited about that. Definitely encourage folks to check out that and other programs that we've had on. So let's see. This should be popping up. There we go. Are there CAR T trials for children? Great question.
Yes, that is a great question, and I apologize because I work with adults, and so I tend to talk solely about adults. But there are definitely CAR T trials open for children. We have several here at UNC in blood cancers, osteosarcomas, osteoblastomas. So yes, there's definitely CAR T trials available. In fact, the initial CAR T was based on CD19 in acute lymphocytic leukemia in children. So that's actually what kind of started the commercial CAR T world.
Okay.
Yeah.
Well, thank you for that. We do have a couple of more minutes for questions, and while we're waiting, let me ask side effects, CAR T side effects. What sorts of things are particularly debilitating, and how do you manage those?
Yeah, so that's probably going to be primarily cytokine release syndrome, which we use tocilizumab to treat. That's usually in the first week or two and can be low blood pressure, low oxygen levels, or where you run into trouble there.
Okay.
We're getting much better at treating that. The neurotoxicity is where people have seen fatalities in the clinical trial space. Rarely, but it does happen. And so that we're getting much better at treating as well. We're treating it kind of more aggressively and earlier, using steroids more often, and so
Gotcha.
getting much better at that as well.
Gotcha. I'm going to jump ahead a couple of slides and then I'll come back. Oh, it looks like we had one just come in here. Here we go. Do you think we will ever have CAR T trials for AML, MDS?
I hope so. There's a lot of challenges in treating the myeloid malignancies, and so the key is going to be to find a appropriate antigen. So there's definitely work being done on that, some in the basic sciences here at UNC, and I'm sure at many, many other institutions. So I hope so. None that I'm aware of now.
All right. Well, thank you for those questions. I'll take one more look in a minute, but let me, oh boy, every time I say that. Here we go. Okay. I'm not clear about this. Could you explain the source of commercial CAR T products a little more? Are those T cells from the patient's T cell or allo donor?
So commercial CAR T products right now are entirely autologous products, meaning that a patient that needs to be treated themselves, we apheresis them, take their T cells, attach the CAR to it, and give it back to them.
Right.
And so right now, all commercial products are single patient, single product, which is very high cost, high labor, high time.
That 4-week span that you mentioned. Yeah.
Yeah.
Oh, okay.
Yeah. So that's all we have thus far.
Okay. And let's see, I think we have time maybe for one more. Here we go. How diverse are the clinical trials, and what challenges do you see in getting diverse patients to participate?
So in general, clinical trials for CAR T are mostly directed at the disease state, and so that's where I think that is definitely an area where we can improve. I think targeting a more diverse population would be helpful. We're mostly finding things where patients have high resources because the treating centers are all centralized. And so once we can expand out into the community, I think we can start to reach more people. But the diversity of clinical trials is definitely something that can improve upon in the CAR T space.
And again, I definitely encourage people to check out Dr. Charlot's work and that Shaping the Future of Cancer Health Equity lecture. We'll try to have Dr. Charlot on for one of our other series sometime soon. All right, let's go ahead. I want to say thank you, people in North Carolina, for their funding of this program through the University Cancer Research Fund and the UNC Lineberger Comprehensive Cancer Center. We want to thank the team, Venny Obore, John Powell, Oliver Marth, Andrew Dodson, Patrick Muscarella, Barbara Walsh, and my Uncle Don for the music at the very beginning there. So